Well, hello everybody, and welcome to the European Achondroplasia Forum workshop on detection and management of foramen magnum stenosis in achondroplasia. So I am Melita Irving. I'm a consultant in clinical genetics at Guy's Hospital in London. So the objectives of this meeting are to understand the challenges and implications of foramen magnum stenosis in individuals with achondroplasia, to review current protocols to understand how and when infants should be screened for foramen magnum stenosis, to evaluate the indicators for intervention and factors influencing the decision to perform decompression surgery, and for us to agree consensus on the optimal process for detection of foramen magnum stenosis and around the decision-making to decompress using the standard operating procedures for the EAF guidelines. And the output of all of this will be to publish the discussion that we have in respect of the recommendations that we make on the management of foramen magnum stenosis in individuals with achondroplasia. Here's the agenda. We're at the top right now. Welcome and introduction from me, Melita Irving.
Yeah.
So at 5:10, Klaus Mohnike from Germany will talk to us about the foramen magnum stenosis in achondroplasia in respect of choices and challenges. We'll have a discussion after that, and then Geneviève Baujat from Paris will be talking about screening for foramen magnum stenosis, followed by a discussion, and we will then introduce the guiding principles upon which we will vote. Then at 6 o'clock, Paul Arundel, my colleague here in the UK, will be talking about identifying indicators for intervention in foramen magnum stenosis. Then we'll have another discussion about another guiding principle, followed by a quick break, because there's lots of work to do this evening, because the next talk then will be by Philip Kunkel from Germany, who will be talking about the decision-making around decompression surgery. We're going to be talking about two guiding principles after his talk, so we'll be discussing those two principles. And then lastly, Heike Hoyer-Kuhn from Germany will be talking about monitoring and management of untreated foramen magnum stenosis, again followed by a guiding principle that we will discuss. And then I'll close at the top of the hour at 8 o'clock, or for 7 o'clock in the UK. So that is our agenda today. So it's action-packed, there's lots to do, and there's going to be a great output at the end of this. Thank you also to our sponsors, to BioMarin, to Ascendis, to QED, to Pfizer, and to Sanofi. Okay, so guidelines for managing foramen magnum stenosis currently. This is where we are right now at 5 o'clock. There's quite a checkered past that's full of controversy. We have not had a consensus until, or even discussed a consensus until relatively recently about how we should manage the foramen magnum, if we should manage it at all. So there have been pockets of practice in different places internationally and even within countries. So there has been no generalized approach for foramen magnum stenosis at all. And that's changed quite a lot recently. And that's how we're having the discussions today. But some of the background to that inconsistency is that for many, achondroplasia has been considered as part of the normal spectrum of body habitus and of stature, and that there has not really been it's not really been recognized or acknowledged that there are health concerns around achondroplasia as well, and we're particularly concerned about the risk of sudden infant death because of foramen magnum stenosis, in particular. So what has started to change the landscape here is that MRI scanning allowed us to use the feed and wrap technique rather than using general anesthetic. So there was of course there is an indication for general anesthetic to be used, and the risks of that have to outweigh the benefits have to outweigh the risks of undergoing general anesthetic. But that was mitigated against when we were able to do MRI scans using feed and wrap. We didn't have to use anesthetics at all, and that's when particularly at our site, we began to realize that significant foramen magnum stenosis was present on MRI scan, but in the absence of any clinical correlates that would indicate that that was what was happening. So no obvious, not always, neurological findings, and no test parameters to do or to look at to give us an idea that there is foramen magnum stenosis, critical foramen magnum stenosis underlying that in that patient. There have been concerns as well that if we start to screen everybody, then we might start to overreact and start to overtreat. And that has been particularly the case in the past with ventriculoperitoneal shunting for hydrocephalus. So using the wrong head circumference charts to track an increase in head circumference that might indicate that there is underlying hydrocephalus developing, and there not being an appreciation that ventricular megaly itself is common, is pretty much across the board in infants with achondroplasia. So there was a lot of over treating in the past, and there have been concerns that doing MRI scanning might recapitulate that, and we might overreact to things that we see, which might be part of the normal spectrum of achondroplasia. So one way or another, this has given rise to differences in local practice, and one of the things that has started to change that is that with the advent of social media and with parents across the world and across countries joining up in discussion, it became clear to them that there were inconsistencies even within the same country about the different clinics and different centers' approach to screening foramen magnum. Some infants were getting an MRI scan in some places, and other infants in different places were not. And so the parents really have started to put this on the agenda to say, well, what do we do? Do we screen or don't we screen? Who's doing it right? Who's doing it wrong? So we were able to establish that a consensus was needed, and that consensus needed to be international, and that we all needed to be aware of the same principles and plan our strategy accordingly, whether to screen or not screen, and if to screen, then how to screen, and if to screen, what are we looking out for, and if we find that thing, how do we approach that? What is the intervention? What is the plan when we discover foramen magnum stenosis? So the need for guiding principles of management must take into account that there are different viewpoints, that people have different experience of achondroplasia, that we have different facilities and we have and different things available to us in our different centers, and that in different places and in different countries and across different families, there are different values and expectations. And so the principles of management that we develop around this must reflect all of those different elements. And they must be workable. There's no point in us coming up with a set of principles that are just not, that we're just not able to implement, or unrealistic expectations. So on that note, this is what we're tasked with today, in being able to develop these guiding principles and agree on the management. Let's go to do that. So before we had the meeting today, we did conduct a pre-meeting survey just to get an idea of the different things going on at different centres by people who were on the EAF mailing list. So the mail shot was sent out to people that we were already aware of through our mailing list, just to get an idea of what the current practices were in their individual centres. And 11 respondents took part in that survey. 10 were healthcare professionals, and 1 was a patient advisory group representative. And the respondents were from across the globe, more Eurovision Song Contest stuff, so Europe and Australia. And not all respondents answered each question. Some were abstained from answering the questions if it wasn't relevant to their own experience or practice. So the majority were pediatric endocrinologists. We had a couple of clinical geneticists, an orthopedic surgeon, a rheumatologist, a general practitioner, and a representative from a patient advisory group. And mostly those, well, across the board, actually, those individuals were from academic institutions or specialist achondroplasia centers based at a major academic center, such as a university hospital. So we will introduce some of the results from that as we go through. But now I would like to hand over to Klaus Mohnike to talk about Foramen Magnum Stenosis in achondroplasia and really take us through some of the choices and challenges as he sees it. So thank you very much, Klaus.
Yeah, thank you, Melita, for the kind introduction and also for the long time collaboration, and I really enjoyed this. My task today is to provide you a brief outline of the special features and implications of foramen magnum stenosis in young children with achondroplasia. I will start with observed serious complications that can occur due to foramen magnum stenosis in some of the children already during the infancy. Furthermore, I would like to present some findings that we found in a retrospective study of cranial MRIs on anatomical features. And finally, I would like to report from a historical cohort of children for whom we have carried out a re-evaluation of the indication for decompression surgery. Next, please. Okay. We had reviewed the papers and the about reports on apparent life-threatening events. And you can see here there is a big study, a historical study from King. They studied in a paper from neurosurgery from the States. It's in a period of 1956 to 2008. And they found 8 out of the 29 children who are treated in this center. They already experienced a life-threatening event. And very currently, they group from the states, which was a group of 4 big centers, and they collected 477 patients or infants and cases, and this was over the period of 1980 to 2017, and I find 18 such called ALTE events. And we in our group of 65 children, which we had counseled or treated in our center, it's for the period of 2005 to 2021, we found a reported ALTEs in 4 of our 65. And then there are several case reports. So altogether, there is no really prospective study, but you see that not only death, but also there are almost life-threatening events are found. The anatomy in the achondroplasia is characteristically by a disturbed enchondral ossification due to this basic fibrous growth factor 3 defect. And as a result, the bones of the achondroplasia are characteristically altered. Here you can see the foramen magnum and the synchondrosis, and you see here 3 or actually 5 synchondroses are working for the foramen magnum growing. So this is the synchondrosis intraoccipital anterior, the synchondrosis intraoccipital posterior, and the synchrontosis sphenoidalis. And there is the possibility to look for the special pieces in the bone with a method called MRI segmentation. This application is an application for where DICOM or 3D voxel data are further analyzed and a 3D model is generated. It allows automatic measurement and analysis of specific structures, like here the foramen magnum, the myelin, the clivus, posterior fossa, tentorium angel, occipital angel, lateral ventricles, third and fourth ventricles, and the cerebellum. And we analyzed from our cohort a group of 35 patients with individuals with achondroplasia. This is the age group, and with a control. And here you can see how this segmentation works. So here we have this possibility for the cerebellum to measure the volume. We can also measure the angel of the occipital angel, and we can measure the tentorium angel. But also here you can see here the myelin volume, the distance in the area of the foramen magnum. You can see here the volume of the fourth ventricle, and also here as an example, the lateral ventricles. And using this method, we were able to show that the volume of the third ventricle compared to the controls are increased. So you can see here the blue signs are much higher than the controls here in red. And similarly, we looked for the volume of the fourth ventricle, and here is a controversy. We found it's almost significant that the achondroplasia has a reduced volume of the fourth ventricle compared to the third ventricle. And here you see the tentorium angel, because the posterior fossa is reduced in the volume. We have also an angel of the tentorium, which is much steeper here over the age groups in the achondroplasia compared to the controls. And if you used the statistical comparison with the Mann-Whitney-U testing, you can see there is a clear significant difference between the diameter of the distance of the foramen magnum and the controls in achondroplasia and the area. It's very clear shown in this figure. For the study, we classified the previous MRIs with the AFMS score over the age. And the figure shows that comparable data, you can see here, AFMS score, we will talk about this furthermore today. Only one child was operated in this group. Here you see all these points showing one child which is controlled with MRI and has an AFMS score of 1. And similarly with AFMS score 2, there are only 2 operated. But in our cohort, we could see that already in the past, the experienced neurosurgeons have used a similar scoring system or some decision. We can talk about this later. Like now, it's already shown by Moira Chang and his group, her group. MRI follow-up examinations were only available in a small group of patients, which we have in control. So what you can see from this concerning the need for repeat MRI to rule out an increase in the foramen magnum stenosis in this figure, but it's only a small group. We could not find an increase in the foramen magnum stenosis, but in a few of them already a decrease in the scoring system. And then we looked for the decompression surgery and the postoperative myelopathy. And very interestingly, we had here 5 patients. It's also a small group, which have an AFMS score of 3 or 4. And this means that all these have a myelopathy. And in the older ones here, in this female with age 1 year, or the male with 10.7 years, you can see the result. So the myelopathy was still reproducible, and also in one of these younger children. But in these children with 1 year, 0.4 years, 0.3 years, after several months or more than a year, they have no hint of a postoperative myelopathy. And in the final part, I will only draw your attention. I think Melita can talk much more about this, that despite the surgery and the surgery implications, there are already a study going on where no results are published yet, but this might be possible that another approach for the foramen magnum stenosis might be possible in the future. So for the discussion, I will summarize. We know that there is an increased mortality, but also an apparent life-threatening event are already reported, and also in our group. It's about 5 to 10% where such an event can be recorded. And second, the craniocervical junction narrowing and the compression of the jugular foramen are most likely for this alter. But this is not the only reason. I didn't come to this to discuss, but we can discuss it later, that there are other possible reasons or causes which might causing the alter. And very interestingly, in our study, we found an increased volume of the third and a reduced volume of the fourth ventricle. We found an increased tentorium angel at a smaller volume of the posterior fossa, which are known as characteristic for achondroplasia. In the retrospective analysis of foramen magnum score, I was very impressed that the experienced surgeons are already performed a very similar approach, who to be operated and who not. And in a very preliminary observational study, we could see that craniocervical MRI here in 15 achondroplastic children shows no increase in the AFMS score after age 3 years. And I only want to give you this hint that there is ongoing study for drug therapy in this cohort. So with this, I thank you for your attention, and we can further discuss.
Wonderful. Thank you very much, Klaus. I think perhaps in the interest of time, if we could just hold those thoughts from your summary slide there, because we will consider these factors as we go through. But I might just move us on to Geneviève's talk regarding screening for foramen magnum stenosis. So thank you, Klaus, for sharing your perspective and sharing your extensive experience with us, and we'll pick up on those discussion points as we go through, please. But for now, I'd like to introduce Geneviève Baujat. Geneviève, vas-y.
Thank you. Merci, Melita. Thank you very much. Thank you for this invitation, and thank you for all this great organization. And indeed, it is a very important subject. So I will take the control of the camera. So indeed, I work in Paris in the Center of Reference for Wearable Disease with Valérie Cornier-Der. And of course, we also are very concerned on this screening. So we will, in this topic, discuss especially on the tools, which tools and when to do this screening. And as it was already said, it is a very old question with still controversial for many reasons. As you know, nearly all patients with achondroplasia have hypotonia and clonus. There is a balance between increased sudden death risk and surgery risk, as Klaus said, and patients may still have permanent narrowing after surgery. So, and there are also spontaneous recovery for a large part of achondroplasia cases, as you demonstrated in your recent study. So the question is how to differentiate those with high risk of mortality and neurological sequelae. And okay, there is a very large importance of the MRI findings, but is it, do we have to do the systematic screening by MRI and other tools? So what are still the best indicators? And these questions were asked a long time ago by Rimoin in 1995, still in 2019, in a lot of papers, we have this question on the screening. And in these quite famous papers in 1995, it was said that clinical items are very important. What are the clinical items for risk of high cervical myelopathy? Marked hypotonia, a lower limb hyperreflexia, and clonus. But once again, all achondroplasia babies have a type of hyperreflexia and central hypopnea. And in this study, they already asked what are the predictable clinical variables. So with the in the survey that you, Melita, presented before this meeting, on the question, does your center have a protocol of screening for foramen magnum stenosis? As you can see, 7 said yes and 3 no. So it is not so simple. Another important paper, Melita, you know it, in 2012, important because it was one of the first with numbers, 5 to 10% of foramen magnum compression, some cases of instability, very rare, and this possibility of symptomatic hydrocephalus, but very finally low. And you also mentioned the fact that it is a controversial discussion. And in this paper, still, you mentioned this risk of cervicomedullary compression for the age 0 to 1 year, so first year of life, and between 1 and 5 years. And without cited this compression for older patients. Once again, it was cited how to, what could be the screening tools, cranial imaging, clinical assessment, sleep studies, but how often and what are the criteria leading to surgery indication. So still in the survey before this meeting, how frequently do you carry out routine screening for foramen magnum stenosis in infants up to the age of 1 year? As you can see, the majority answered only when indicated, and for others, every 6 months, and then every 4 months, and even every 3 months. And so, as you can see, it is not something that is globally shared. Still in the same survey, how frequently do you screen for foramen magnum in young children older than 1 year, between 1 and 3 years? Only when indicated in the majority of answering. And this is every 6 months for 3 centers. Another question, if you carry out routine screening, at what age do you cease routine screening for foramen magnum stenosis? And as you can see, the majority of respondents cease routine screening for foramen magnum stenosis before the child is 1 year old. So what can be screened? What should be screened? Clinical items, head perimeter, head frontal and anteroposterior diameter, tonus, clonus, facial mimic, symmetry, well-being, anatomical conditions with imaging, neurophysiological data, and respiratory events. And phase to that, physical examination, cervical MRI, somatosensory evoked potentials, and sleep studies with polysomnography. We come back to the survey. Which of the following assessments do you routinely use to assess stenosis of the foramen magnum? And as you see, a range of assessments are routinely used to assess foramen magnum stenosis. So it is in many centers a combination of assessments: MRI, polysomnography, clinical examination, neurological examination, of course, on the top, and others. And this is finally a form of consensus, a combination of tools. And then what method of routine screening for foramen magnum stenosis is used in your center? All respondents routinely use MRI to screen for foramen magnum stenosis. So what about this MRI? So it was very well described by Klaus before, so we won't go deep, but it is an imaging reference assessment in 2022, sagittal T2, but also T1 transversal. It is proposed systematically in some countries, as it was said, at 6 months of age, possibly because if we do it too early, we won't have a maximum of stenosis, but there is no recommendation for the assessment in older babies. More and more, it is performed without general anesthesia in expert centers with only a short sedation or rocking the baby. And we also have now a combination of various data quantitative approach, including the foramen magnum distance, but also the C2 to C0 anterior-posterior diameter, the position between C0 and C1, and this line between C1 and C2 with a posterior inclination. And we will come back to that later because there are very deep analysis of the MRI in recent papers. So the stenosis definition is the absence of perimedullary fluid visualization and medullary changes. It was said by Melita and Klaus. But the question is, what is the correlation between foramen magnum measurements and complication risks? And this is not really well elucidated. And the surgery indication stay a complex decision with a need of a multidisciplinary assessments. So this paper that you probably know well is very important. It is a large, very large natural history study, and the risk during the first 2 years of life is also highlighted in this paper. But they also say there is no consensus. And in this American paper from the US, they also say that there are different guidelines, or the systematic MRI and overnight sleep study at 6 months, but for other centers in the USA, only if clinical symptoms. And it was said that there are gaps in knowledge, especially the consequence in adult health still unknown in achondroplasia linked to this stenosis. We go back to the survey. So would you screen an individual over the age of 3 years for foramen magnum stenosis? And as you can see, the majority of respondents would not screen an individual over the age of 3 years for foramen magnum stenosis. And we can link that to what Klaus demonstrated and Melita in your study. As you can see, others that selected yes, one respondent commented that they would screen only once after the age of 3 years, and only in case of referral over the age of 3 years, or only if symptoms. So we, of course, wanted to mention this very interesting and important grading by your team, Melita and Klaus, this Evelina AFMS grade from 0 to 4, which is very useful and that we use also now here, and that may be a common tool in various centers. We also wanted to mention this paper with a quantitative approach of the posterior cranial fossa and the craniocervical junction in asymptomatic children with achondroplasia. Because, as you know, there is this foramen magnum stenosis, but also all other items are very important, including the PCF, the posterior fossa synchondrosis enlargement or stenosis, which may be linked to the stenosis. And as you can see in the conclusion, there are a relationship between the shortening of the clivus and ventriculomegaly and the premature closure of PCF synchondrosis, the shape and the growth direction of the supraocciput bone in patients with medullary compression. So it was a quite short series with only 13 patients, but emphasizes the importance of fine measurements, quite technical, in MRI global analysis. There is also a recent paper by another team proposing an MRI grade. It is another score that we don't know yet here in our center, with predictors of cervical myelopathy and hydrocephalus in young babies with achondroplasia, with, as you can see, various measurements. Alors, second, so after imaging the sleep respiratory studies, the overnight polysomnography, and we have two major papers showing that there is trying to answer the question: is there a correlation between abnormalities in polysomnography and the foramen magnum stenosis in achondroplasia? And in these two papers, this one from White and his team, and in our team in Paris, on 43 patients, there is no direct correlation between the various index and the surgery indication. But there are quite a high rate of obstructive apnea, very low rate of central apnea, and it was more interesting to guide the head and neck management. So the third, after imaging, polysomnography, the somatosensory evoked potentials, that is quite interesting, but not performed everywhere. And finally, they conclude in this paper that we might have an interest of this paper, of this tool, in very young babies, especially with medial nerve and posterior tibial nerve stimulation. But actually, this is not a type of screening that is commonly performed. So, of course, as it was said by my colleagues, and we mentioned before, we probably need a combination of results of various screening. Importance of overnight polysomnography, clinical exam, and MRI. We, of course, don't want to give surgery indication on only one screening result, by instance, grade 2 or grade 3 MRI with your grading. So it is important to discuss case by case in a multidisciplinary manner. Alors, when should regular screening be seized? We already mentioned that with the surveys, there is no consensus. Possibly in this study already cited, they propose that when no concern after 2 consecutive MRI, but caution because there are some rare late indications. And in this paper, they mentioned the possibility of foramen magnum stenosis even in older children and adulthood. This is not something that we are really avoid. So we are really we know that here. Alors, in summary, there is a higher rate of mortality in achondroplasia, leading to all this discussion, and we think that there is a great importance of integrating screening, regular physical examination, imaging, MRI with possibility, with this quantitative approach that we probably have to better know, PSG, maybe the electrophysiology, but there is no consensus about the frequency of this assessment and the age of SIS. Repeated evaluations in the 2 first years, yes, probably. Anesthesia consideration for MRI is very important to be able to do it easily, and if general anesthesia is required, it will be a break in some centers. The new score, two new scores, maybe more, are very important. And of course, we also would like to finish with the importance of longitudinal registry with common minimal assessments, long-term data analysis, and this consensus discussion. Thank you.
Thank you very much, Geneviève. That was a fantastic overview of the different concepts that we need to bear in mind as we consider our first guiding principle. I don't know if we could just have a look at the next slide with that guiding principle on it. Yes, these are all the guiding principles that we're going to be looking at today, and we will be voting on each of these principles. The idea being that at the end of the meeting, we will have reached consensus, and that we'll be able to put down in writing what our guiding principles are around management of the Foramen Magnum. So here they all are. So the first one is on the next slide, I think, please, that we could have a look at. This is the guiding principle that is going to come from the points that Geneviève has just been discussing, has just consolidated for us. So here is the guiding principle. We've got about 11 minutes before we need to make an absolute decision. But in the first instance, let's do a first round vote. So if everybody has that in their minds, all infants should be routinely monitored for Foramen Magnum Stenosis every 2 to 3 months from birth to the age of 1 year. Thereafter, every 3 to 6 months until the age of 3 years. And after 3 years, monitoring for Foramen Magnum Stenosis should be based on individual needs and local protocols. That's what we're going to be voting on. There are some finer points around that we'll discuss around how we screen. Can we screen earlier than ever before, prenatally, in fact, and what things should we consider for beyond the age of 3? So let's vote, let's discuss, let's vote again just before the top of the hour. So please, guiding principle, screening and detection. Do you agree with this guiding principle? Okay, there we are. So do you agree with this guiding principle? Yes, and 83%, and no for 17%. I'd be interested to hear from the knowers what they are thinking. Would anyone like to share their thoughts around this? Martin, I can't see hands. I don't know if you can give me. Oh, actually, Oliver, I can see.
I'm not seeing any hands at the moment. Oh, sorry, Oliver Semler.
Yeah, Oliver Semler, please take the mic.
Yeah, thanks. I'm one of the no's because I think we need to specify who has to monitor. I think every 2 to 3 months in a specialized center, maybe far away from home of the patients, is a bit frequently. And same with the period 1 to 3 years of life. If we include local pediatricians, then that's fine. But I think every 2 months in a specialized center is a bit frequent.
So we had 6 voted no.
I voted no, Valérie Cormier, because I agree with Olivier, and I also want to know what is your meaning of routinely monitored? How is the monitoring being to be performed? And every 3 months, it's a lot, I think, also. The frequency is really difficult to follow.
That's great. Anybody on the yes side like to say why they think this is? And I think the question you asked Valerie and Oliver was around, particularly around who does it and where it's done. Sorry, is that Klaus coming in?
I think yes. I said yes only for the clinical side. So this also intended that these families are sometimes need some counseling, and this is something which might be more frequent in the first year of life. I don't know if it's necessary all 3 months, but I think 2 or 3 times in the first year would be a good idea. And one is with the MRI, and the other ones might be clinically.
Okay, Professor Said?
Yeah, I have the same. So I voted no, and I have the same comments. I think if we are talking clinical monitoring, then maybe every 4 months or quarterly. But I think it's a bit too excessive. And it's difficult for the families to be able to come, especially if they have to come to a specialized center for such monitoring.
Kate, I know it's not per the EAF protocol, but it might be interesting to put that if we changed it to every 3 to 4 months, would that change people? Those who voted no, if we said every 3 to 4 months, would that change the vote? Valerie, would that change your vote?
Yes.
How about every 6 months?
That's against the question, but per the EAF protocol, the 87% is already sort of
okay.
passed, but we can certainly change it to another date to see if it gives a better outcome. So, Kate, Melita's back.
I am back. Sorry, were you talking amongst yourselves? Thank you.
Just to update, so there were a couple of comments that somebody voted no, which was included Valerie, Oliver, particularly said that perhaps 2 to 3 months was too often, but 3 to 4 months might be a more acceptable number that may change some of the votes. So it's up to you whether you think we'll do a re-vote at 3 to 4 months or stick with the vote that's already been passed at 2 to 3 months.
Well, you just say something in addition to that, and probably we can avoid changing the wording, but I think everyone would be happy in that when let's be specific, when we're talking about screening and detection, we're not talking about an MRI scan. We're not necessarily talking about an MRI scan every 3 to 6 months. We're talking about clinical assessment. So Geneviève in her talk outlined the different elements that could constitute screening. It's not just the MRI scan. She said there are lots of different things that we need to take into consideration in respect of clinical evaluation. So let's be clear about that. We're not talking about a general anaesthetic for an MRI every 3 months. I don't know, Ines, if that appeases your position slightly, because you're right, it is a tremendous burden for the family. And the stress of all the assessments and waiting for the results and acting on the results is hugely stressful for families. But we're not talking about MRI scans every 3 to 4 months. And this is what we will spell out in the discussion around the guideline, the guiding principle.
We feel comfortable with the wording at the moment, or should that be every 3 to 6 months?
It was 3 to 6 months originally?
It was 2 to 3 originally, I think. Okay.
Then I personally would be happy with 3 to 6. I don't know if that's any objectors before we put this back to another vote.
Melita, would you want to put in the word clinically monitored?
Sorry, Martin?
Do you want to add the word? You mentioned clinical monitoring. But
yeah. Unless we put that as part of the discussion, that when we're talking about monitoring, we're talking about the whole shebang, not just MRI monitoring. We're talking about everything.
Absolutely.
I think we can have that as part of the discussion, because the message is we need to be thinking about this as a possibility every 3 to 6 months, and giving it consideration, although we're not doing MRIs every 3 to 6 months.
well, let's go for a vote on that then.
Does anyone else want to, how are we doing time-wise? Does anyone else want to?
Yes, anyway, all babies are followed also in many centers by a local physician. So we can imagine to have a 4 hands follow-up, targeting on the clonus and the tonus, and it is a good way to involve the local physician. We know that it is not possible everywhere, but usually in many countries, a baby see a physician, a local physician, and if we explain him to follow tonus, clonus, and this is a communication discussion, something that we can exchange with the local physician. And so a clinical follow-up by 3 months seems possible, focusing on some symptoms.
Yeah, look, thinking specifically around the Foramen Magnum, Geneviève, yes?
Yes, yes.
Florian, does that answer your question you've posted? Isn't that 2 separate aspects, assessment of Foramen Magnum and checkups every couple of months? And Susie, you said the same. But
Florian has his hand up, as does Inez and Mohammed. And
yeah.
So Florian,
okay.
Want to say something?
We have got Florian. Do you want to say something?
Well, I guess it's a little bit unspecific, the question as it is worded at the moment, because it's not clear who is going to monitor and what is going to be mentioned and what is going to be checked. So the reason why it's going to be 2 separate aspects, well, you're not going to do a Foramen Magnum Stenosis or the checkup for that every 3 months, but there is going to be regular checkups in that time. So I don't know, are we talking about an MRI every 3 months? Are we talking about a checkup, a clinical checkup? That's not clear from the wording as it is phrased right now.
Yeah, so that was the point I was trying to make about that. In concept, the guiding principle is that we have this in our minds every 3 to 6 months, that we need to monitor for this. Geneviève outlined in her talk that there are different ways to monitor for Foramen Magnum Stenosis. It's not just the MRI, there are lots of other things. So I think so that will be spelt out in the discussion, but the concept here is that this needs to be on the agenda every 3 to 6 months. Is that everyone else's thinking?
Inez has a question. Inez has gone, I think.
I think now Melita just cleared out the monitoring, because most likely many parents will take the monitoring as MRIs, and it's quite stressful for that. So I would suggest to have clinical monitoring, which differs a lot and is not MRI specific, and maybe within the first year if we are here talking about MRIs, because in many centers, non-expert, not referral centers, scheduling an MRI can be a very long challenge, and having many months in waiting time, which can be again stressful. So it's really the wording here that needs to be clearer.
Yes, I think that's the message that's coming across. Thank you, Ines, and I think that would make Florian happy as well. But I don't want us to make a guiding principle that doesn't emphasize the importance of the role of MRI in this, because as Klaus has already told us, as Geneviève has already told us, clinical indicators are not enough without the MRI. They do not tell us which children have critical Foramen Magnum Stenosis. So yes, we could add something about clinical monitoring, but it has to also include imaging from my viewpoint.
Mohammed, has his hand up?
Mohammed?
Yes, I mean, I agree with the last comment. So we need to put clinically, and it's a matter of rewarding. And I would like to add that in Italy, that's routine to see healthy children every 3 to 4 months. So I think that is normal follow-up even for healthy. So we're talking about achondroplasia, and I guess 3 to 4 months could be acceptable by adding clinically monitor, which doesn't mean MRI. So we didn't have any consensus about how many MRIs we need to do and how to score this. But clinically monitored every 3 to 4 months could be acceptable to my view.
So I've added clinically in. What do we think now?
And the last comment, sorry, from Joachim.
Joachim.
I just wanted to add that we have to have in mind first availability of MRI, as was mentioned in one of the last speakers, and both polysomnography. At least in our area, it's not very easy to get an MRI in sedation or with feed and wrap technique. And the same is true for polysomnography. And so from my perspective, in addition to a physician-based screening, family education for clinical science is as important as the 3 months intervals at the physicians to detect early cases. And Philip and Klaus know the case. We just stumbled across a 6 weeks old chap who was only presented because he was in our area, and friends of the family realized a different breathing pattern, and then we stumbled across a myelopathy. So I think education of the families, in addition to a screening program, clinically monitored, is a combination which needs to be taken into account.
Yeah, I agree with that, and I don't think we're capturing that in that statement because we're not featuring imaging.
So I would propose, on what I've heard, Melita, that we go with routinely monitored. I think because that we can cover that, as you say, in the text, and I think what I heard was 3 to 4 months in the first year, and then 3 to 6 months in the second year onwards. I think that probably, for everything I've heard on that call. If we can get, I think, one last comment from Svein.
Yes, I just wonder whether we need to split this recommendation. There's one recommendation for clinical monitoring and add a new one to include MRI, because that was the point we did not reach or consensus on when we had the international consensus statement as well, because somebody want to have 3 to 6 months, and I think we ended up within one year. And I think maybe we should split it and discuss MRI separately as a specific recommendation itself.
Yeah, I think that's a really good point, and that's possibly what Florian and Suji were suggesting earlier on. That we're looking at 2 different concepts here, all with the same objective in mind, the Foramen Magnum assessment, but 2 different ways to do it. Can we split the guiding principle, do you think, or?
We can, yeah. So all of it should be routinely monitored clinically.
Still routinely redundant with every 3 months. Sorry about this, because we're saying. Yeah, because we are specifying every 3 to 4 months. So.
Okay, so every 3 to 4 months from birth to the age of 1 year, thereafter every 3 to 6 months till the age of 3 years. And then we would need a second principle based on MRI.
Yeah.
So if we can perhaps take a vote on this one now, and then add the second one in, so we know what we're voting for.
Yeah.
That's, everyone's happy, because I don't want us to confuse the voting. And then in general, per the SOP, just have this discussion before we vote the first time. The first time we've changed it a bit, but let's see if we get this voted in. The results are, there we go, 100%. So
well done, team. Good work.
Did you want to phrase another word on MRI? Because I don't know how MRI is used, but did you want to put some more word, propose another principle there? Melita, will move on.
Let us move on, and during the move on, consider the wording and come back to vote for that. Would that be possible?
Yep. So if we do the second vote, this one, then on the level of agreement, then say the second question now. Okay, so that's 26% 10, 21% 9, 32% 8, 15% 7, 3% at 6, and 3% at 4. So that's
the majority pretty strong on their agreement. So that's good.
Yeah, that's brilliant. So let's move on to the next session, and then we can come back at the end of the recommendation at the end of the session.
Yeah, so we're off to a great start. Beautiful. Thank you very much, everybody, for that contribution and for that excellent discussion. Thank you, Geneviève, for your talk and for giving us the tools to be able to do that. Thank you. Now we're going to move on to the next session, which is identifying indicators for intervention. And I'm delighted to welcome Paul Arundel, paediatric endocrinologist from Sheffield Children's Hospital, to take us through this one. Thank you, Paul, and welcome.
Thank you, Melita. Can you hear me all right, Melita? Is that all right? Okay. So
all good, thank you.
Good evening, bonsoir, guten Abend, and the rest. Here we are. So there's a little bit of overlap. I'm going to briefly go through this presentation because I think the discussion is probably the most valuable thing. There's a lot of you around the table who know pretty much everything that I'm going to say and have direct experience of it. So I'm going to work through clinical assessment, polysomnography, MRI, make some general points that will have occurred to many of you before, and then we'll move on to the discussion. This is a question that came out before this meeting, asking people what people's indications were that an individual required screening for foramen magnum stenosis. I'm presuming that meant screening with an MRI scan. So this is not for intervention, but for screening. You can see it's a variety of views expressed there, some highlighting clinical signs, a clear statement that someone thinks all patients should have at least one MRI, and various other things that you can read there. And this was the response to the question, which assessments are necessary to indicate that intervention for stenosis is required. And again, you can see the MRI features heavily there. Some people felt as though CT was necessary for deciding on intervention, and there were other elements there which were important. Okay, so clinical assessment. Many of us will see, if not all of us, will see children with achondroplasia on a regular basis. And as has already been said, history and examination are key in screening, as we've just all agreed. And the focus in large part is around neurological signs, respiratory history, and to some extent examination, and a focus on the development of these children. And as we've already discussed, the timing of these assessments, how early this should be done, and with what frequency, particularly in the first few years of life and subsequently, are things to be decided. When I've highlighted with a red star there saying a real example of indicator for intervention, that doesn't mean the other things are unreal. It's really to highlight cases on an anecdotal basis, personal experience in the last few years of things which have really pushed us towards a decision for intervention. So it's to bring some real experience, real cases to bear on this. If you look on the right of this slide, you can see a child who's had an MRI at 2 months, a screening MRI scan, and then a subsequent MRI scan done at 9 months, and that was done in response to development of new excessive clonus. So an example, a concrete example of a child who's developed new clinical signs, and that has directly led to repeat imaging and subsequently intervention. I saw this child very recently, in fact. Hyperreflexia has been mentioned. That's something which can guide us, and hypotonia, relative to other children with achondroplasia. But sometimes the degree of hypotonia can be profound. At other times, it can be subtle and actually only be identified as significant hypotonia when post-operatively they're clearly they've got a better tone and they're moving far better than they were beforehand. So sometimes it can be retrospective. Also, some asymmetry to signs, I think, is a clue. I've got at least one child who I saw fairly shortly before they ended up having a respiratory arrest, and they'd been examined by myself and a very experienced orthopedic surgeon in the week before, prior to their presentation, and we hadn't elicited any neurological signs whatsoever, either of us, on examining this child. But in retrospect, speaking very carefully to the mother who's a healthcare professional, I suspect this child had some very subtle hand preference in infancy that was probably giving us some kind of clue. So any kind of asymmetry, I think, is useful. And as has been already mentioned and highlighted in the talks, head growth is useful, and significant developmental delay, of course, is perhaps a clue to a problem. Polysomnography has been mentioned. To some extent, this is beyond the expertise of many of us around the table, and we lean on our respiratory colleagues to guide us with this. And you can see the amount of data that we get from readouts with full polysomnography. We're relatively fortunate in Sheffield to have good access to this and enjoy good support from our respiratory colleagues, but I'm well aware that it's not something that's universally easily available. The threshold, the indication for polysomnography would need to be determined. Do we think that everybody needs it? And if they do, a bit like the conversation with the MRI, what's the timing? What's the right timing for this, or is it a one-off screening tool? And what do we use as an indicator for repeat? Certainly, central apneas and hypopneas, a significant number of these has, in our experience, been something that's helped us decide around intervention, perhaps with borderline, so-called borderline MRI scan results. But it has to be interpreted, with the overall picture, of course. And we need to bear in mind that sometimes an obstructive picture is something which can be centrally mediated. So it's not necessarily a simple analysis that will lead us to an intervention. And availability and interpretation are obviously absolutely key. And it is a burden on families, and we need to bear that in mind. It's an overnight stay and requires wiring up the child and having them stay in a foreign environment for some time. So MRI, we've already covered a lot of this, but I think it's clear that MRI is a tool to guide intervention. The question of when we should undertake an MRI is, we're starting to touch on it already. What's the threshold? What's the indication? That's why we're talking about this. Timing. Should we do one very early in life to identify very severe craniocervical junction stenosis, or is it something that we're happy to leave to the second to 6 months or 9 months? And as with the child in not the slide before the last, is there a value in doing one early in life to screen and then another one later when we're perhaps going to capture the majority of significant cases? Anesthetic versus no anesthetic. Is there a value of a wrap and feed, or is the degradation in the images such that it's not worth doing a wrap and feed, and we should always proceed to a general anesthetic with the attendant risks and the attendant difficulties in terms of organising and waiting and so forth. There are details around scanning that, again, we need some radiological expertise, I think, to guide us. Positioning is something that people have raised in the literature, and certainly the size of the foramen magnum is to some extent dynamic, I think. And there's what precise images we need, whether we need flow studies, in what positions, is a little bit of detail that's worth looking at if we're going to provide detailed guidance on this. But again, as with polysomnography, availability and being realistic about availability is really important. Before I go on to the next slide, you can just see here, as a comparison here, we've got a child's MRI there. This is someone who presented with a respiratory arrest and fortunately has done very well. But you can see the corresponding CT scan that was done as in a critical window of time. And you can see that there's a useful information about the foramen magnum stenosis, even on that CT scan. Interpretation has to be done, I think, alongside the clinical findings. We need timely communication between radiologists, the clinician leading the care, and the neurosurgeons in order to really extract the full value from an MRI scan. The value of grading, we just need to bear in mind that the grading system is an attempt to categorize what we're seeing. It's not necessarily something which is in itself guiding treatment decisions. Certainly, if we're seeing grade 4, obviously this is Moira Chung and Melita and Dominic's work. Grade 4 with alteration in the CSF, in the cord signal is a clear indicator in most people's book for intervention. But there is this uncertainty with these lesser degrees of narrowing. And I think it's worth making the observation that there is a degree of subtlety within these grades. So for anyone who looks at these scans regularly and tries to grade them, it's not so simple as saying that grade 3, you've lost all CSF signal and you've got a compressed cord. Sometimes you've still got signal around the cord even in grade 3 according to this system, and in grade 2 it's not complete loss of CSF signal around the cord, you can just lose CSF signal posteriorly and so on. So there's a degree of subtlety, and it's a tool to help us categorize and understand what we're doing, perhaps rather than a tool that will tell us precisely what we should be doing. And of course, we need to not forget these other tools with CT scan and evoked potentials. So it's in this group with the grade 2 and grade 3 where we're using other information perhaps to guide us in treatment, or the neurosurgeons rather are using this to guide their treatment. So finally, end with some general points. I think it's fair to say that you can have significant compression with fairly subtle or completely absent or complete absence of other indicators that there is significant compression which may lead to harm in the child, and that needs to be taken into account when we're thinking about the guideline. We do need to think a little bit about process, who will undertake the assessments, and again that's been touched on by who will undertake, say, 3 monthly assessments. Would it be the local team or not? And sitting above that is the question of who is responsible for the coordination of investigation, screening, and a timely review of any information that comes to us from clinical examinations and from assessments. And we perhaps need to think about adopting a stepwise approach, whereby there's a first tier of screening and then a second tier of doing other things, or do we think it's routine to just undertake MRI? And can we undertake some of these assessments in parallel, or should we see them in series? And of course, different approaches at different ages, I think, is something we're already finding common ground about. So there we are, Melita. I don't know if you want to open that for discussion at this point, or how we take it forward.
Yes, absolutely. That's fantastic. Thank you for giving us that, that background and that baseline to launch our discussions. Thank you, Paul. Would anybody like to share thoughts straight off, or should we do a round one vote and then come to the discussion? Let's do that. Let's have a look at the guiding principle, please. So this one, where signs of compression are observed on routine screening, infants should be referred immediately to a neurosurgical specialist, and close monitoring should be carried out according to local protocols. So yeah, some finer points around that, such as what are the signs of compression? We need to establish that. Does the neurological specialist need to be specifically experienced in achondroplasia? And is there a close monitoring protocol that can be recommended? So, okay, let's have a vote, please. Do you agree with this guiding principle? Yes or no? Okay, 90% yes and 10% no. Would anybody like to kick off the discussions with their thoughts? Anyone who said no? What are you thinking with your decision?
I'm Liesbeth Steers, a Netherlands pediatrician, and I follow one child with achondroplasia in primary care. And I doubt if, at the moment, if you leave it up to primary care or secondary care to do the regular neurological check, I doubt that they're sufficiently knowledge to do so. So I personally, I'm even trained in genetics. I participate in achondroplasia clinic long time ago, but still, you're not used to seeing children with achondroplasia. They're different in many ways. So how are our primary or secondary pediatricians? They should be trained then if you want to do this. That's why I said no.
Okay, so so Elizabeth, if we were to stipulate specifically that this was in a specialist clinic, in a specialist setting, would that change your mind?
I take it that in a specialist clinic, they will follow these protocols. So I take it this is part of the specialist clinic. But on the other hand, always go to a specialist clinic with a child with achondroplasia is also not wishable, because it's long distance sometimes and sometimes stressful. I know from the parent I see that it's sometimes stressful, certainly also the sleep registration. So there should be some mingle with primary care, or what can be done outside expert centers and people who see many children with achondroplasia, and what can be done in primary care. I think there can be made some guidelines to that. I personally looked at the Rich Pauli's guideline, and then that's very extensive.
Okay. Thank you for sharing your experience. Paul, did you want to come in?
Yeah, I was a no as well. Melita, you when you read it out, you said neurosurgical, but the statement is neurological specialist. And when I certainly, if I see signs of compression, I'll probably arrange an MRI scan myself and start at that point to liaise with the neurosurgeons. But I don't think I've ever involved my neurology colleagues, so I don't know if neurologically is seen as an all-encompassing term, including neurosurgeons.
Yeah, that's a good point, actually. Yeah, we might have to change that wording, Kate and Mark, because we don't refer to neurology, we refer to neurosurgery once we've got it to a certain point as physicians for these children. Yeah, great point. Thank you very much. Anyone else like to come in with a comment? How are we doing for time? We've got plenty of time. Well, we could. I mean, if no one else has anything to add, I might just add here that increasingly we have access in our specialist setting, admittedly, to home sleep studies, which are as good in many respects as the inpatient sleep studies, and this may kind of pave the way for the future, because if we're starting to get burdensome with our guiding principles and what monitoring should be undertaken, then perhaps devolving things out to home would be more palatable for families that are going through this. I don't know if Inez, do you have any thoughts on that?
It's fine, has his hand up as well, Melita.
It's fine, yeah.
Yeah, just a comment on the, I completely agree with the neurosurgery, but just where there are signs of compression, I think the further management should be taken care of by an expert center in achondroplasia. I don't think a general neurosurgeon not seeing patients with achondroplasia is not good enough. I think they should be experienced in this quite difficult discussions. So I would like to add that this should be further taken care of by a specialist center experienced in achondroplasia. That's my suggestion.
I think it's a very good point. One of the things I was concerned about at the start of this meeting, I highlighted over-treating and procedures being undertaken by people who aren't experts because they read the scan in a certain way that's not necessarily a finding that we would consider to be serious compression. So yeah, I think that's a great point. Mohammed?
Just to add, sorry.
Yeah.
And the last part, the local protocols, why do we have that part of the sentence? Could we just delete that part?
Yes, that last phrase altogether. Yeah. Yeah, yeah, I think that's reasonable. Thank you. Mohammed?
Yeah, it was the same as Fane. But just back to stay online with the first statement, where clinical signs of compression are observed on screening. So because we have already decided about what is routine is 3-4 months as, and just to focus and highlight on clinical signs.
Yeah, that's a good point. Like it. Thank you. Great. Joachim and then Ines.
Yeah, I was wondering, I'm still struggling with that statement, because in case a primary care physician has certain signs of central apnea, let's say that. So there's, as we already stated, there's not perfect signs of compression available. So is that a direct track to the neurosurgeon? I'm having trouble with that, because that is omitting, from my perspective, the MRI really demonstrating that there's compression. And I'm not sure whether our pediatric neurosurgeons, and Philip might make a comment to that, are happy if they get all patients who have a suspicion of compression.
Yes, good point. So there's compression and there's compression. So which ones are we going to send to neurosurgery? Philip, do you want to come in there?
Yes, Melita, thank you. I think that's a really good point, because if we would do it like that, I wouldn't have time to do anything else than
like this.
These great little patients. But I think the most important point is that we have to have the MRI early enough, and that therefore we need to have people who can really indicate when to do these MRIs. And I think that leads us to the point that we should also talk about an MRI for every child with achondroplasia, and at what time point we would think that is the best thing to have that. And in Germany, we have this discussion. We had this discussion some 2 or 3 years ago, and we kind of came to the conclusion that an MRI in a neurological normal developing achondroplasia kid would be important between 3 and 6 months of age, and that's early, and it's not possible, I think, in every medical system, but I think in an ideal setting world, we should do it like that.
Great, thank you. Do we need to qualify where signs of compression? Do we need to qualify that? Signs of significant compression, Paul, what do you think, based on your presentation?
Well, as I say, I think if there are clear signs of compression, I think my next step is MRI scan. So I think Philip's right. I think, we do need to give thought to how this sits alongside, what we want to say about MRI scans. I think certainly if you're convinced there's clear clinical signs of compression of spinal cord compression, I would involve a neurosurgeon. Any signs, it's the certainty of whether the signs, isn't it? As you say, it's not necessarily about significance; it's about the certainty that you have that they are signs of compression rather than something else, and that becomes difficult, particularly when you're talking about sleep apnea and perhaps some other things. Okay. Sorry, I'm not offering you a clear answer, Melita.
Yeah, I mean, I think we are going to flesh this out in the discussion, aren't we? In the publication for the guiding principles. So perhaps that will all come out at that stage. So yeah, maybe we don't need to further qualify signs of compression. Ines and then Oliver.
Well, taking the previous comments, I think we are in this section on what are the signs that actually puts the situation of risk and being immediately is quite strong, referred to a neurosurgeon. And is this an immediate in-person referral, or is something that a clinician or the physician that firstly assess the child and assess a sign, just reach out to a neurosurgeon? So this immediately is quite, it makes us a strong stand, and definitely capturing which are these signs that can be of risk. I think it needs to be very clear when this is presented.
Yeah, I think that's a really good point, because I can think of many occasions when we have said to our parents, we found compression, you need to see the neurosurgeon, and they're booking the cab there and then to get to the hospital. So we have to be careful with what we mean by immediately. It's not an emergency, but it's not something that we can wait for. However, waiting lists are such that we might not be able to get someone in there immediately. And there's compression and there's compression. So I think I think that's a very good point.
So the way we worded it, Melita, in the overall guiding principles, when we talked about referring on diagnosis, we used as soon as possible.
Yeah, okay. Yeah.
Which may be better here.
Yes, I think that's right. Thank you, Ines. Really good point. And lastly, can we hear from Oliver, and then we need to do a vote, because I see it's our break time. So Oliver, please share your thoughts. Thank you.
Just a short comment, because we discussed who is thinking here and sending the patient somewhere. Maybe we could change it to should be referred as soon as possible to a neurological examination in a center experienced in the management. Then it's still a bit open if it needs to be seen by a neurosurgeon or by someone who has experience with achondroplasia and organize the MRI first before sending the patient to the neurosurgeon. So.
Okay, I see your point. So when I read this, I imagine that one of the sources of signs of compression is the MRI scan. Paul, did you think the same?
I've re-raised my hand because I was going to make almost exactly the same point as Oliver. Again, it's about perspective, isn't it? So if this is guidance for our colleagues who are not expert in achondroplasia, then in reality, what I would want is for them to refer into a centre who is able to undertake a proper assessment of them, a specialist assessment, which I think is very similar to what Oliver was saying. And not necessarily for them to make a direct referral to neurosurgery. So there's an issue around perspective perhaps here.
Yeah. Martin, do you have a view on that? Who we're trying to address this?
I think I'm not. No, I think it's what we've got.
Okay.
It's not my role. My job is to make sure we go through the process really. So if people are happy with what we have there, or is there a post to change the wording? I'm not really sufficiently expert to have an opinion in this one. Happy to go with what we've got there, because I'm conscious we had a very strong positive vote at the start as well. So I don't want to, we're hearing some changes. We don't defer backwards, if you like. So I think we.
Yeah, absolutely. And again, I think we can flesh this out in the discussion points around the guiding principle in the publication to be clear what we mean in this setting and that setting. I think we could probably be clear on that. So
discussion, absolutely. This is a great discussion. So
yes,
we have a revised one here now, we should probably vote on.
Yes. So why don't we vote on this as the guiding principle? Can we do that, please? Okay. Very good. And then thank you, everyone. And then how about the level of agreement? How yes were your yeses? Thank you very much. So yeah.
Can I make a quick comment?
Yes, who's that?
I think maybe there's an easy solution. We just have to change back neurosurgical specialist to neurological specialist, because what we put in after changing that was center experienced with achondroplasia management. I think then it's all solved, no?
I don't know, Paul, you felt strongly on that.
I mean, it might be terminology, but we wouldn't necessarily refer to a neurology specialist. Maybe someone who has expertise in assessing neurological complications of achondroplasia.
That's what I meant.
Sorry, I missed that comment, Philip. You sort
of. Sorry, that was exactly what I meant. Just change it back to someone knowledgeable in neurological examination and not a neurosurgeon.
Yeah, that's. I mean, that, from my point of view, that sounds fine and sensible, actually, Philip. I think I was slightly confused when we were initially talking about you mentioned neurosurgery, Melita, when you sort of introduced it originally. So it depends what the purpose of this is. But yeah, I mean, I'm happy with what you've suggested, Philip.
I guess the slip came with me because I think if there are signs of compression, you need to get that child to a neurosurgeon to consider that further.
And as you suggest, Melita, all of these comments and opinions can be fleshed out in the manuscript to make sure that we cover all of the comments per protocol, where we've got a 97% agreement.
We have voted, so that will stay. But yes, these points are very valid, and we will flesh this out in the discussion for the publication to talk about the different settings in which this may occur, if that's okay with everyone. Thank you. All right, let's close this session and go to the break. I just wonder, we've thought of some wording for the second guiding principle, the one that we split off. Maybe should we pop that on the screen so people can have a think about that over break time? And then we could potentially come back after the break and vote on that before we move on. Would that be possible, CSAS team?
Yes, we can absolutely do that.
Thank you very much. So we're a little late coming to our break. We're 10 minutes late, but let's take 10 minutes and be back here at 5:02, please, to crack on with the next vote and the next session. Enjoy your breaks, everybody, and thank you for a first great half. Okay. Do we have Philip ready for the off?
I'm very ready.
Okay, so just before we move on to Philip, on a related topic, here is the guiding principle for the splinter principle from the first round of discussion. Will we take a vote on this now? Would that be okay?
Does anyone want to change any wording? I think we've only got time for one vote, Melita, on this one. So, there's any strong feelings?
Yeah. We have one chance and one chance only, because we need to press on. So, okay.
I'm seeing no immediate hands up, so let's go to a vote.
Wonderful.
Agreement.
Great. Thank you very much, everybody. Thank you, CSAS team, for producing that. Now let's move to the next area for discussion. Delighted to welcome Philip Kunkel, a neurosurgeon from Germany, to talk about the decision-making process for decompression. Thank you very much. Philip, over to you.
Thanks very much, Melita, for the invitation and for the kind words. I'm very happy to be able to maybe add a little bit of my surgical perspective to this problem. I cannot see my slides. Are they on or?
You should have control. If you click a couple of times, you should be able to advance.
Oh, okay.
There
Thanks.
we go.
Yes, so this is lovely Mannheim for the enthusiast. And I just want to make a couple of comments about surgical technique and maybe also about some things that already came up in the great talks that were given earlier. And maybe I can add then in the end my personal or our personal way to handle this and show you how we conduct the examinations and MRIs and all this. So I think I can skip that. We all know that and have seen that this is the foundation of the problem. Just another visual, how small foramen magnum in a child with achondroplasia really is, also in comparison to a much younger child in a CT scan. And one point I wanted to make, maybe that's interesting, because many people think that the foramen magna just shrink in a way, you know. But I think they grow very, very slow, and I don't think they get, if you have a succession of different MRIs, you wouldn't see them getting smaller, but the content is growing, and but the foramen is not. And I think there are many cases we've seen in MRIs where we had the opportunity to, you know, look at images from many time points. In some cases, as many as 5 in the first year of age, which is of course a little excessive and wasn't really asked for by us. But sometimes you get this, and there's a lot to learn from that, I think. This is a classical picture of a pretty severe stenosis, and this is the child after surgery, and you can see it's now in every dimension bigger. And I come back to that because that also depends on the surgical technique, I think. This is a CT scan again, where one of these decompressions was done. Not by me, I have to say, and you can maybe you have to imagine that the original foramen had this posterior border. So the only effect of the only visible effect of the decompression was this little, and that's just not enough. And I want to emphasize that it's very important to also widen the foramen magnum. It's much more important, I think, than to extend it posteriorly. So and these the red dots here, this is something that I've seen in some children with achondroplasia, maybe not many, but something like maybe 20% or something like that. They grow an extra bone here, and it's in the area of the synchondrosis, the posterior one. And in these decompression surgeries, it's important to also remove them. And that's not so easy, because this is now a surgical picture, and this is here you can see the decompression that is already done in the occipital bone. And here I have it's a very small drill. It's only 2 millimeters in diameter here, and this is this extra compressing bone from the lateral sides, where you have which I'm very convinced it's important to reduce that to achieve a good amount of decompression then. So maybe one could argue that only 2 or maybe only 5%, something like that, of all achondroplasia patients maybe really need decompression. And I think when we analyze our data, it's about 10% right now. And yeah, what are these factors that we find these children? And that was already said before. It's of course for me the most important thing is the extent of the foramen magnum stenosis, and therefore we have the score, and of course the clinical symptoms. And coming back to our discussion from later, I think there are maybe 2 different groups of patients. We have a sort of an emergency patient where we have these early clinical symptoms that suggest compression of the cord, and they are not that many. I think the majority is a children that never would show these signs, and which we would screen by MRI. But there is a smaller group that can be symptomatic very early on, and they have to. I think these are the ones we have to. They cannot come too late to an expert, I think. And I think in my perspective, sleep studies are also an important factor, and electrophysiology is maybe not that important. This is one of the survey results, and also most people said as an answer for what are the indicators that you would think are important for decompression, MRI, and the majority said it's not only one factor, of course. This is another example because I wanted to make a point about quality of MRI and comparability of different MRIs. I have the feeling in Germany, at least, we have a lot of these T2 weighted images that are flow sensitive. And this is, in many instances, it's very helpful because you can see the fast moving CSF is getting dark, and so you can appreciate the flow if it's restricted, or if the CSF can reach every compartment. But in judging the foramen magnum stenosis, it's not so helpful, I think, because you have these, if you have a look here, the myelin and these flow artifacts are pretty much or are very similar, and it's not so easy to say, is there an indentation, is there CSF and stuff like that. So I think it's much more feasible to use T1 images, because here you can really see it's the same, it's the same image from the same examination. I mean, so there's a lot of space here, right? It's a great zero, more or less. And yeah, that's one point. And the other point is resolution. I used to see a lot of MRI images where only maybe 3 cuts are made through the sagittal cuts that are at least close to the mid of the foramen magnum, and if they are not completely in the middle but a little off, and then you only have 3, it's also in many cases not so easy to judge. And that maybe brings us to the discussion point from earlier with the feed and wrap technique. it is, of course, good because you often get an MRI instead of waiting for anesthesia time slot for that. But in many cases, it's not so easy to judge them. So I would make the point that would like to make the point that these judgments of these MRIs should be done by people really very experienced with judging those. And this, of course, is very useful. It was covered earlier. And in the here in the question regarding would you or do you use a scoring system? It was very much cut it in half. 50% would use it and 50% wouldn't. Of course, neurological development is important, and that is also something Paul was covering very good. It's not so easy to judge these findings in babies, especially. And I think this tool is very helpful. I always have it in my phone, you know, and have a look on it, because here you can really see what is the percentage, what is the percentile if you have a baby, and you see some developmental steps are already taken or not. You can kind of make points here, and then you can really judge in a good way if this child is developing normal for a kid with achondroplasia. So for me, there are three groups of patients I would think that should have decompression. And one, of course, is the neurological symptomatic child with a significant FMS. And I think significant in my perspective would mean at least 2 AFMSs, 2 to 3. And then, of course, in combination with myelopathy signs and stuff like that, I would make the decision to do a decompression. And I think more or less everyone in the group of AFMSS4 should have a decompression. And then there's a third group, I think, and these are the neurological asymptomatic children that have sleep apnea diagnosed in sleep studies, and also as a third component have a significant, of course, Foramen Magnum Stenosis. And this question dealt with who is making the decision to do the decompression. And there are 2 ways again. One, the majority said the multidisciplinary team should do that, and I would think so too. And the other part thought that a neurosurgeon should do that. But I think a neurosurgeon should always do it when in concert with the colleagues, you know. And this would be our way to do these decision makings. We get a lot of MRIs by specialized pediatricians who would send them, and they would include some data of the patient age and clinical symptomatology, and then we would review them, and then we would contact the family or by phone in many cases, and actually in most cases I would call them and just say, okay, there's no severe stenosis in your kid, you don't have to do anything anymore. When the age of 1 is when you have an MRI at the age of 1, because we've seen many cases when the MRI was done very early, like with 2 months or something like that, and that's when it's not when the stenosis is not very severe at that point, it can be severe around the age of 1 year. And Klaus and I think I can say that we had the feeling that that 1 year is in many cases sort of the peak of the severity of the stenosis. And in other cases, we would invite the family then and the child for an examination and interview in person here in Mannheim then. And maybe we would initiate more diagnostic sleep studies and so on. And then we would discuss with the family and make a recommendation to do surgery, for instance. And of course, in the end, the decision has to be taken by the family. Yeah, I think that's all I have. Thanks very much.
That's wonderful. Thank you very much, Philip. Yeah, I'm interested in the concept of the family being so much a part of the decision for you. Would that still apply if it was an AFMS4?
I think maybe I never experienced a family where I couldn't convince them in this stage not to have not to have surgery. Everyone decided to have it. But it's a good question. If there would be the first family who would refuse, I think I would call really social services and escalate that, because I don't think the freedom of decision is endless.
Yeah, absolutely. Great. Thank you very much. Well, we've got two guiding principles to discuss, to vote on. One of them is around the who makes the decision. So we'll come to that in a moment. I don't know if anybody has some thoughts straight off the bat that they'd like to share following Philip's talk, his presentation. Thank you very much for that. I think we're getting the sense that it's lots of different things come into play when you make the decision, and lots of and there are lots of different situations, lots of different combinations and permutations of what could happen and what situations we could be in to make those decisions. So thank you for spelling that out to us. Does anybody want to say anything? Should we look at the guiding principles then? Can we do that? Are we ready to do that? Florian, there are two statements. There's one just after. Can we flick to the next statement as well, just so we can have overview of both the statements, and then we'll vote on the first one.
Yes, of course. So the second one covers a joint decision.
Yeah. Thank you. Let's pop back to the first guiding principle. Let's go to the votes. Why not? Please. So shall I read it out? I'll make sure I get the wording correct this time. So the guiding principle is the decision to decompress the foramen magnum should be made using a combination of clinical, neurological, and imaging assessments evaluated by a neurosurgical specialist, and no single indicator should be used in isolation.
Sorry, can we again put in something that would clarify that the neurosurgical specialist is really experienced in this type of surgery? Because most aren't, it has to be a pediatric neurosurgeon that is specialized in these children, I think.
Do we also have to include foramen magnum stenosis, or?
I'm not sure, Suji, because we've got decompression, so that suggests stenosis.
Okay.
we will again flesh it out in the discussion.
Sure. Thanks, Melita.
Thank you.
I think we can close the poll there, please, Taya. Thank you.
Great. Thank you very much. Will we move to the strength of your yes? Great. Good
So
stuff.
strong agreement on that one.
Thank you, everybody. Thank you for that. Okay, let's move to the next guiding principle about the joint decision. So the guiding principle here around decompression is the decision to proceed to decompression of the foramen magnum should be made jointly by a neurosurgeon experienced in achondroplasia, the individual's family, and the wider MDT.
So Melita Mohammed's got his hand raised.
Mohammed.
Oh yeah, that's for the statement about if we need. I mean, it was too long to my view, because the combination means that no one in isolation. So, but this was the last statement.
Should we have a look at that again?
Yeah, because the decision is to decompress using a combination. I mean, combination is a combination. It means no single indicator should be used. I wonder whether this is redundant.
Yeah, okay.
I think we had the vote, so I think we could just, if everyone's happy to edit that, I think that's probably a fair point, Mohammed, just to change it rather than take a revote. We've had a very strong agreement.
Yeah, we don't need another vote. I agree, but yeah, it's a good point. Again, we will. Yeah, that's a slightly nuanced thing to say about the single indicator again, which will come out in the discussion. So yeah, thank you very much. Thanks for pointing that out. Okay, so the decision to proceed to decompression of the foramen magnum should be made jointly. So let's vote on that one, please. Thank you very much. Strength of agreement next. Thank you very much. Thank you. We had I think maybe one or two people who thought no to the guiding principle, and a couple of people who are don't have a strong sense around this in respect to their answer. Does anyone want to make a comment on their response to this? I don't see any hands up. I think if we don't have any pressing comments to make, which is fair enough, we can move on and congratulate ourselves that we're back to the timings on the agenda. So great, thank you very much indeed, Philip. That was a great session. Very good to have your perspective, and you've got some fantastic images there. So thank you very much for sharing that with me. That 2mm drill bit is quite impressive as well. So yeah, hands up to everything that you do. Thank you. Okay, so let us move on to the final session now. And let's please welcome Heike Hoyer-Kuhn, who is going to speak to us about monitoring and management of untreated foramen magnum stenosis. So in the whole mix here, whilst we've been deciding whether to screen or not screen, there have been a bunch of children that have been screened and a bunch of children that haven't been screened. So that still presents us with a group of children that we need to consider. So thank you, Heike, very much for sharing your perspectives on this and taking us to the final guiding principle. Thank you. You're on mute, Heike. It's the first time I've had to say that this evening.
Thank you very much for the nice introduction, and good evening, everybody, also from my side. Well, yes, my task as the last speaker is to introduce a topic which is difficult, I think: monitoring and management of untreated foramen magnum stenosis. So I have control. So the objective is the introduction to a discussion on how to manage individuals with previously untreated foramen magnum stenosis. And I would like to start with a case because, as we will see later in the survey, this type of stenosis is really rare and only a few colleagues have been in contact with such individuals. So we saw in our outpatient center last year a girl, 7 years old. She was diagnosed with achondroplasia at birth and was followed up in a different center until this contact. So as the mother told us, the last MRI scan was completely normal, which I cannot believe, but that's a statement the mother gave us at the age of 3. I didn't receive the pictures before this talk today, so we just have this statement. And the course of presentation in our center was that the mother recognized sleeping problems in her daughter, and they went for a polysomnography where sleep apnea was detected, and this was for 6 to 9 months now. So the further clinical neurologic exam in our hospital was without symptoms. And despite this MRI at the age of 3, of course, we ask ourselves, might this be a foramen magnum stenosis causing the sleeping problems? And thinking about the next steps, we referred to a paper from 2020 giving statements about health supervision for people with achondroplasia. The most of you, I think, know this paper. And there it is presented that especially neuroimaging, we talked a lot about today, of course, is indicated if new diagnosis, but also in the older kids should be performed as indicated in case of neurologic problems or sleeping problems. And the same for the polysomnography. So an MRI screening was performed in our hospital. And I think I have not to say a lot about this image. The child went directly to a pediatric neurosurgeon and was decompressed within a couple of weeks. So this is just to present how things can go in daily life. And as a next step, I would like to present the survey results where this topic also was asked for. So half of the respondents were aware of individuals with untreated foramen magnum stenosis. And interestingly, out of these, 5 colleagues which reported that they know about such children give completely different answers. Why maybe this happened or why this child was not treated. And for example, delayed diagnosis was one reason, but additionally, there were statements as hardly any child has a normal MRI, grade 0 and grade 1 based on Fornarina et al. Paper were used. So question is not clear. And interestingly, the PAG representative said that in Australia, the healthcare may not have policies and procedures relating to this specific issue, which I couldn't believe, but it seems to be very different in all the countries. And that is something we should keep in mind when we are talking about a special cohort of individuals. Second question, do you have a management strategy for individuals with signs of compressed foramen magnum later in life? And there have been 4 out of 9 respondents which reported that they have no management strategy for such individuals with signs of compression later in life. And the other 5 said, take an MRI and refer the patient to a neurosurgeon. The patient should be managed more closely at the achondroplasia clinic or by the multidisciplinary team. Looking for neurological signs, whatever this might be, compression on MRI, no contraindications. Later in life is misleading. What do you mean? Adolescent, transition. In case of science, the strategy is the same as for children older than 3 years, and clinical and MRI at annual visits. So you also see here that the answers are completely different. And yes, people say they have a strategy, but the kind of strategy differs. What do we know from literature? I just pointed out one publication which came out very recently, consensus statement, international consensus statement on the diagnosis, multidisciplinary management and lifelong care of individuals with achondroplasia. And I just went through this manuscript again to see what are the recommendations for Foramen Magnum Stenosis and other recommendations which are covering this topic. And yes, there are recommendations, of course, for Foramen Magnum decompression in symptomatic children, but no special recommendation for the group of children which had a stenosis but have not been treated in the past. So this underlines, I think, the need for a guideline or consensus statements from our group, and there are still ongoing questions. Which options do you see for ongoing management if the individual shows no sign of complications? And which strategies should we use for intervention in the case complications arise? And takeaway, it is not known how many individuals have unidentified untreated FMS. I think it's really rare, but there are children, and policies should be in place to identify and provide ongoing support for these individuals. And yeah, the next step, I hope that Melita will follow up to gain consensus on guiding principles, also for the special cohort, but I assume that this would be even more difficult as the topics we covered today and in the earlier talk. Thank you very much at this point.
Wonderful. Thank you very much, Heike. Yeah, it's a really interesting point, and I'm sure everybody is aware of patients that they know who have undetected foramen magnum stenosis or might have foramen magnum stenosis, and how hard do you go after that as well. So yeah, there are children that have presented after we have decided to screen for foramen magnum stenosis, so those undetected, as Heike has already explained. I don't know if anyone would like to share their experience straight off the bat. I don't know, Svein, do you have anything to share with us from your experience of older people with achondroplasia?
Well, not exactly on this topic, actually. The foramen magnum stenosis was not, many of my patients were quite old, and at that time you didn't do either CT or MRI scans, so we don't have very much to compare.
Okay.
Would be nice to know.
Yeah, and Philip, I don't know if you've got a perspective on this, because I know that our neurosurgeon, Dominic Thompson, is not keen to operate on very young children, but because of the risks associated. But what about the older children? Do we need to be guided by risks of the procedure?
I think one important thing is that I think many of us have seen MRIs of older patients where you have, let's say, a very roomy foramen magnum. There's a lot of space around the myelin, but what you see is a myelopathy sign. So, of course, what we make of this is that we would conclude that it was at one point very narrow. And I mean, I'm talking about unoperated people, of course. So I think what we don't have enough data. I think it would be very important to have more MRIs on many more children and many more age groups. To maybe we can define, you know, different growth patterns of the foramen magnum, and maybe we can even define, you know, some signs that we can early on pick up and group people in risk groups or something like that. But therefore we just need to know more, and I think there we are back at the topic of the register. No? Yeah.
Yeah, and actually in a few of the trials, we're also monitoring foramen magnum in older children, because they started off as young and they stayed in the trial for long enough for us to be monitoring their foramen magnums later in life, so later in childhood. So natural history around this will be important to determine as well, won't it? And I think one of the points that's being made, I think, is that these things are often now set in stone. Something happened earlier on, undetected, and it's now set in stone. So the neurosurgical intervention is probably not going to be warranted. Is that fair to say in most cases?
Yeah, I think so. So to be honest, after this case, we screened our images, and yes, there are only one or two other individuals which has been screened for FMS after the age of 2. So most children are stopped in the age group about 2 or 3 years, and I think that would be important as a first step, as Philip said, to get an impression how foramen magnum develops over time, and what we see in children without any severe clinical problems. And then we can get a better approach, which children should be screened, and which ones have an indication for an OR. So yeah.
Thank you. Klaus, do you want to come in with something?
Yes, I think I have seen some MRIs where a myelopathy is looks very severe, but the clinics is not so. So the child is moving around and is not really showing any clinical signs. So that's my question to Philip and Paul. Maybe what their experience with the myelopathy is. This a great risk factor, or is myelopathy something where children also can develop in a good condition?
Paul, do you want to comment? Or?
I think Paul's had to leave, unfortunately, but yeah, Philip, you go for it. Thank you.
Yeah. So, I mean, from a neurosurgical perspective, we of course have a lot of experience with people in general with myelopathy and narrow spinal canals, cervical spinal canals, and CCJs. So, in many cases, it's very severe. So, I think it's hard to you know, find a myelopathy sign and not do anything about it. But the question, I think, is it still narrow at that point? And if you have these older children with a myelopathy sign, usually the ones that are neurological very well off, usually it's not narrow anymore, right? Or Klaus, did you?
That's correct. That's correct. I show these MRIs, and what I think I remember a child age 5 to 6 and the parents don't want to go to surgery, and I observed them for a while and see that it develops fine. So, but the MRI later, there was some liquor around, so there was already some space, but still it has myelopathy. Yeah.
Yeah, I think that's a complete different thing. Then maybe I can make a pragmatic recommendation. In our practice, what we do is when we have a child that is maybe 3 years old and the foramen magnum stenosis is not severe, but also it is still there, let's say a grade 2 or to 3, then I usually make the recommendation, do an MRI when the child is at about 7 years old, and the MRI can be taken without any sedation and any risk for that matter from the imaging itself. And I'm curious what will come out of these images at one point. But that's maybe a little bit like a back, like like a backup plan then.
Yeah, I think there's really a big need for long-term follow-up and to have collected all these cases so we get more experiences. Yeah.
Yeah. What actually, I want to bring Silvio in before I ask my question. Silvio's been waiting patiently. Silvio, would you like to share your thoughts with us?
Yes, I would like to tell you that I started in limb lengthening in '81. So and before making this procedure, I usually want a complete MRI of the spine, and it is absolutely rare to find a stenosis of foramen magnum in a child over 7 or 10 years. And the children usually don't have any sign, any neurological sign. So I don't know why, but this is my my practice, my experience, and this is, I think, is very important because from '81 or '82 to now is more or less 40 years.
Where do you work, Silvio?
Sorry, I'm working in Gaslini Hospital in Genoa.
In Genoa, okay.
Italy.
Yes, I know.
Of course, as you can easily understand.
Yes, well, you're very welcome here today with us. So thank you for sharing that. I just wonder, could we have a look at the guiding principle, not necessarily to vote on it now, but just so that everyone can see what it is that we're expected to consider here, because this may or may not be possible. So the guiding principle that we will ultimately vote on, of our last one, is that local protocols should be established to guide management of previously undetected foramen magnum stenosis in older children and adults. So I don't know if anybody now reading that proposed guiding principle has anything that they would like to share with us, any thoughts that anyone has having read that, because we're going to be voting on that in a moment. Anything around local protocols, anything that might inform those protocols to decide whether we should be screening and what the indication for intervention is. Mohammed?
Yeah, I wonder whether local protocols could be really confusing. What are local protocols? So if we don't have any international.
Claudia, I think that's you.
If we don't have any recommendation, that's really confusing to tell people about local protocols. I don't think that people have local protocols for patients with possible or potential foramen magnum stenosis in older life.
Yeah, I think I agree with that. Yeah, I mean, yeah, I think this is quite a tricky one because, you know, as is being outlined here, we don't know enough about the natural history. We all have different experience of it.
It could be personalized, something like, you know, just to take into consideration the single case, but
Yeah.
I don't think that local protocols could be discussed here.
No. Yes, let's have a look at that wording.
I mean, if it's something we can't find consensus of, it then does lead into the research agenda and the things that we need to look at moving forwards.
Yes, it does. Yeah. Yeah. So you're suggesting keeping it the same and voting on it, and then the vote kind of takes the decision about future development of that as a guiding principle.
Just a suggestion, Melita.
Yeah, it's fine.
Instead of local protocols, could you say something about individual management on an individual basis or something?
Yeah, I think that's what Mohammed was suggesting as well. Yeah, with the
personalized. Yeah. Personalized, maybe.
So perhaps if we say maybe older children and adults with undetected foramen magnum stenosis should be managed on an individual basis.
Perfect.
Okay, that's fine.
Yeah, very good. Does anybody else have anything to contribute to this? Okay,
I'm not sure, but should we recommend decision on MDT basis, because we don't know where this individual child is in what kind of hospital or practice setting this child is followed up, and therefore it might be good to say something about different specialists or specialties, so including the neurosurgeon and the primary caring physician, for example, or MDT.
Could we say, could we say at a center experienced in the management?
I think MDT is fine. And
I think MDT,
if we say personalized decision by the MDT, it means there are some professions working together, but it's personalized for this child.
Yeah, and if that's exactly what we do in practice at our center.
Yeah.
So yeah. Okay, I don't see any hands up. Shall we take it to the vote? So we now have the guiding principle of older children and adults with undetected foramen magnum stenosis should be managed on an individual basis by the MDT. I was just thinking what we're saying is previously undetected foramen magnum stenosis. Does that stuff up the voting? I think that's probably what we all understood by it, but the point is that it's now detected, but previously it wasn't. Martin, the adjudicator?
With a 96% agreement, I think that's nobody's objecting to that word. I don't think that you're saying previously was what was implicit, so nobody objects that we can.
Thank you.
We'll keep the 96% as it is. I think that's staggering. How strong is the agreement, though? How strong is it?
Let's see. How yes was your yes? Well, fantastic work, everybody. I think we have got some good decisions there. That's really brilliant. Thank you very much. Thank you for everybody for voting. Heike, thank you so much for your presentation and for guiding us through that last principle. Thank you. I think we can start to summarize and close now. Unless anybody who hasn't said anything, I can see several friends in the participant list that haven't spoken yet. So if anyone has anything burning to say, please do raise your hand. Otherwise, I will make moves to start to close this. Okay, I got the message, right. Okay, so thank you very much, everybody, for the presentations, for listening to the presentations, for voting, for helping us develop these guiding principles around such an important area of achondroplasia, the foramen magnum. I think we've got some really great principles developed here, and I'm looking forward to putting this together to formalize those. So thank you. So with potentially severe consequences and differences in local protocols for managing foramen magnum stenosis, it has been important to find consensus to ensure a quality of care for patients and for their families. Routine monitoring should be available for all children, and that's what we're trying to get across with these different streams of work that we're all involved with in many different settings, to try and establish a good quality of care for all children with achondroplasia. And where concerns have been raised on routine screenings, we've now been able to think about indicators for intervention and how we can assess for those, and so to make the right decision and to be consistent in the decisions that we make. And processes should be in place to support the decision-making process for decompression of the foramen magnum. So the sense that we're getting from this meeting in particular is around the importance of the MDT and for families, so making joint decisions in these settings. And there will be individuals who have not been captured by routine screening procedures because of the natural history of the routine screening. And so we're going to start to think now about management strategies to support those individuals for the future as well, because I think that's going to be more and more commonplace as time goes by. There will be people looking at the standard of care that we practice nowadays and thinking, well, my 10-year-old child didn't have the benefit of that advice back in the day. What do we need to do? Do they need an MRI scan now? How do we need to monitor them? Should we be worried that they weren't involved with that kind of screening protocol? So I think this is going to come up more and more as we start to solidify the decisions that we make around these guiding principles. So there are some outstanding questions, some things that we need to develop in the future in the context of how we research these concepts. We've talked previously at a workshop arranged by Moira Chung, my colleague, at the last international conference on children's bone health in Salzburg, Austria, when we talked about ultrasound being an easily accessible modality to view the foramen magnum, but although it might be useful antenatally, postnatally, we don't have any don't have much experience there, and we don't have any normative curves. Antenatal MRI can detect foramen magnum stenosis, and there's limited data on that, but it is being generated. And then there are other things that we can look at with respect to screening using MRI, so looking at the emissary vein enlargement, using dynamic studies, flexion extension views in particular on MRI to look at the flow of CSF and effacement of the cord, and to measure flow rates, and Philip has alluded to that and its value in assessing the foramen magnum in his presentation. Ventricular index can be measured for hydrocephalus, and cerebral atrophy can be identified on antenatal MRI, on MRI. I think that really remains a gold standard imaging modality to really get all the answers we're looking for as a screening tool for foramen magnum stenosis and the other cranial neurological complications of achondroplasia. We're going to need more studies on prognostic factors as well, especially finding out some more about that natural history of the foramen magnum when intervention isn't implemented. So just a few other things for you to be aware of, things coming up, exciting things coming up. So the EAF is also planning a face-to-face meeting, Advances in Achondroplasia, probably in November, December time, somewhere in Central Europe, with co-chairs of Professor Geert Mortier and Professor Mohamed Magni, which we're very much looking forward to. It's going to be a range of sessions, with plenary sessions, workshops, which you can choose between. Focus on recent advances, Lisbeth. I hope that answers your question there. And that will be CME accredited. And I think the next slide is going to give us a flavor, a bit more of a kind of granularity around that. No, it's not. So we will be talking about recent advances for that workshop as well. So if you want to register for the EAF website, please do. There is the website, achondroplasiaforum.com. Kate has just put into the chat the email address that you can use to get some more information about the Achondroplasia Forum. If you like, the EAF website. This meeting is going to be on that website too. There's so much information on that website that is really, really valuable and is up to date and is keeping abreast of all the new developments in this fast moving and exciting field. Another meeting to tell you about as well is at the International Conference on Children's Bone Health in Dublin in July. And there's going to be a workshop dedicated to spinal pathology in children with achondroplasia on the Saturday, the 2nd of July, before the main meeting starts. So please look at the iccbh.org website for more information around that, and please do register. And with that, I'm going to say thank you. Thank you to you all for participating in this meeting and joining us today. Thank you very much to all the presenters. We've had some really fascinating talks, and thank you so much to you all for sharing your experience and your insight and your knowledge with us. It's proven valuable in helping us discuss the guiding principles, and so watch this space for that and for taking this workshop forward. And lastly, well, not lastly, thank you also to our sponsors for supporting the meeting today. We're very grateful for your support, because we can't do things like this without you. We can't continue to move the knowledge, improving knowledge across everybody who comes in contact with achondroplasia in some way, shape or form without your help. So thank you for that. And a massive thank you to the CSAS team as well. You have worked so hard to make this a very successful meeting, and it's a really impressive number of people that registered. So thank you all to Kate, Martin and Taya. Thank you. And with that, I will leave you in peace to have a nice evening. So bonsoir.